Thank you kindly for that great introduction, and it's nice to be here. I'd like to thank Dr. Yen and Dr. Gonzalez for inviting me to speak to everyone today. Sad that I can't see you in person, but I'll do my best to envision you all in front of me. I'm going to talk to you everyone today about briefly about injection treatments for the management of osteoarthritis. It's the major part of my practice at present, and I'm actually in between a series of injections right now. So 10 minutes should give me just enough time to speak to you guys and get back to it. I can't emphasize it enough that the management of osteoarthritis is I think of it as a ladder, and there's a stepwise approach to managing it. And we start off with conservative measures, and it takes a team to treat people with osteoarthritis. It isn't just my part might be doing the injection, but we have to look at the whole person and really treat them educate them, lifestyle modifications, rehabilitate the injured area. There's modalities, there's medications, there's braces. When people's pain doesn't respond to these conservative measures, we look at things like injections, which I'll talk to you about today. And in other cases, people will go on to surgery, and another type of injection that I offer, which is radiofrequency ablation, which I'll introduce to you briefly. Every injection must have a goal, and I think it's super important that we establish goals if you're going to be going for an injection. And the injection goal shouldn't just be to reduce pain, because the pain is going to be there. If you have osteoarthritis, it's a chronic degenerative condition that's going to have pain. So the goal should really focus around function, things like improving your mobility, improving your sleep, improving your quality of life, doing something without pain, perhaps. So there has to be a clear goal, and you shouldn't just go with I want to reduce the pain, because most injections, in fact, all injections are temporary reduction of pain. So they should really focus on a goal. In my world, the goal is to either diagnose the symptom. So sometimes I'll just use dental freezing or a local anesthetic to freeze the joint and make sure that's where the pain's coming from. Sometimes I'm using an injection to help someone participate in a rehab program through physiotherapy or working with a personal trainer or a kinesiologist. Sometimes it's to bridge the gap between surgical management. So someone who's waiting for a total joint replacement and they're really disabled, the injections can help them through that stage. And sometimes it's just knowing that they have a chronic condition, and it is to reduce the pain and improve the quality of life for those who've really maximized those other conservative measures like weight loss and exercise. When I'm talking about injections today, I'm referring to the use of anti-inflammatory medications, the use of hyaluronic acid, regenerative medicine techniques we'll touch on very briefly, and then I'll also highlight radiofrequency ablation, which can treat some people. Starting with corticosteroids, I think there's a lot of myths and they're out there. I think that they certainly still have a place in the management of osteoarthritis. A lot of patients come nowadays. I find they're getting a lot of information out in the community that it's going to harm them in some way, and that maybe they should avoid it. It's certainly something we want to use in the right instance, and I find that they're extremely effective in people with osteoarthritis who have an inflamed joint. So if somebody has active inflammation and it's not responding to the other measures, like the conservative measures I briefly touched on, it'll be very effective at reducing inflammation. The question is how long will that last for? It ranges from 6 weeks to sometimes as long as 6 months. It's temporary. And the frequency is what's up for debate, because I think that people need to know that most times the cortisone will be very effective the first time they have it, maybe the first couple times, but over time, it tends to be less effective. We call it a diminishing return. It just won't work as well over and over again. And we also can't put steroid in a joint. We'd like it to last at least 2 to 3 months to justify doing it. So if it's less than that, I wouldn't do it again. And for safety purposes, we want to avoid putting cortisone in a joint within a 3-month period of time. And there's also a total maximum amount of cortisone you can have in your body within a 3-month period, and that would probably be about 3 doses in any joint. So, if you're getting into both knees and your shoulder, that's about it in a 3-month period of time. That's a bit debatable, but that's my general rule of principle. We have to be aware there is some short-term side effects, things like insomnia, flushing of the face, sweating, people feeling on edge or anxious, and that's just temporary for 2 or 3 days. And we do have to use caution in using corticosteroids in people with osteoporosis, because it could theoretically lead to the body suppression of the body's own production of hormones, which can maybe make the bone density worse. So I tend to avoid using it unless it's really kind of an urgent case. And I think we should also caution that we're not using this in young, healthy joints. It's not this like, I think there's this image out there that we're trying to put it in people's healthy knees that are to get them back out on the sports field. That's not really the case anymore unless there's a clear indication for it. The next type of injection that you may have heard of is something called hyaluronic acid or viscosupplementation. The reason I put the Tin Man here is that basically what we think, when hyaluronic acid is naturally produced by our body, it's a complex sugar, a polysaccharide, and basically hyaluronic acid is in everyone's joints. It's a lubricant, it's shock absorber, and what it does is in a healthy joint, there's a lubricant there that helps like I said, lubricates the joint and helps the joint move freely. As a joint becomes degenerative or develops osteoarthritis, our body's less effective at producing hyaluronic acid, and the joint is lacking this lubricant. So we have a way to inject a man-made lubricant called hyaluronic acid. There's various brands out there that we can utilize, and we inject them into the affected joint. It's usually most effective in people with mild to moderate osteoarthritis. That's where the best evidence is, and it's the most evidence is for the use in the hip and the knee. I think of it like a lubricant or a shock absorber, and it kind of resembles like it's quite a thick substance that we inject into the joint, and we do it with an ultrasound or X-ray guidance to put it in the joint, the affected joint. It's really safe. The really only risk is a temporary pain flare. People can have increased pain or a flare of pain for a couple of days after the procedure that can be quite uncomfortable, but that's less than 10% of the time, and it still doesn't affect the efficacy of it. It doesn't work for everybody, but I do suggest trying it in terms of the escalation of care. The downside to it is that it's often not covered by healthcare. So most people's health plans will not cover hyaluronic acid unless you have some of the more, the better private plans will, but like Blue Cross or people on AISH, for example, I don't believe it's covered. So we can sometimes get compassionate doses, but and the other option is private pay, and it's in the realm of like $200 to $300 for one treatment, and ideally it should last 4 to 6 months to justify using it again. The other area of kind of exciting realm of medicine for injection treatments for osteoarthritis is regenerative medicine, and that's using your body's own materials to help promote healing and regeneration at the level of the joint or the soft tissue. The two major things some people may have heard of is platelet-rich plasma, which requires the use of our own blood to help with regeneration. And then there's stem cells. I'm not going to talk much about stem cells today because stem cells are not available in Canada right now because of Health Canada has banned the use until further research is done. PRP or platelet-rich plasma is basically taking your own blood in a tube as if you were getting blood taken at the lab, and then we spin it in the centrifuge and we separate the components of the blood that contains the platelets. The platelets they contain growth factors and healing factors. When you get a cut or you injure yourself, you'll see that you'll get a blood clot at that site. That's the platelets coming to the site of the injury and starting to stimulate healing and growing of new skin. So we think that injecting it in a joint can be helpful with both helping kind of improve the toxic environment in an unhealthy joint and also lead to potential healing and reduce inflammation. It's been around now for at least a decade, but it's becoming more and more commonly used in osteoarthritis. And I do find it's an effective treatment. It doesn't work for everybody. I find it either works or it doesn't. And the people that respond are very happy with it, and then others don't. It's extremely safe because it's really just injecting your own blood. The downside is that it can be expensive. It's a private procedure, and it can range from $200 per dose to up to $600 or even $800, depending on the clinic. There's controversy out there because various people use different techniques and it's not standardized necessarily. So sometimes the quality of what PRP you might get at one clinic could be very different than at another clinic. And like I said, it doesn't necessarily work for everybody. Stem cell injections I alluded to, but essentially that's taking your body's own stem cells from either adipose or bone marrow and injecting it into the affected joint. And it's thought to be basically a more potent form or a more potentially stronger form of regenerative treatment that can help potentially regenerate injured joints and cartilage. It's not been proven to do that at all. I think it's more of it's just an effective form of pain management, but further research is needed. And like I said, it's not being offered right now because of Health Canada has banned it until we can find more evidence about its safety and its efficacy. And it should be, people who do travel to the United States to have this procedure. Tends to be very expensive, and I tend to not recommend it in most patients because it's unlikely to, like, you know, if you're spending $10,000 plus your travel, it's just extreme. It can be, for the benefit you might get right now, it's probably hard to justify. The last area of injection that I'll briefly touch on is something called radiofrequency ablation. And this is using a needle that's guided towards the affected joint. And we can use heat energy, like in the form of cautery, to basically burn the affected nerve that's giving feeling to the joint. So it's becoming really kind of an effective treatment for the use of treatment of knee osteoarthritis. And there's also techniques for other joints, including the hip and the shoulder, but those are less common. But essentially, if you think about it, every joint has nerve endings that that sense feeling or sense pain, and that message from your knee or your hip goes up to your brain, and we sense pain. And so if we can basically put a needle at the site of the pain and interrupt that signal, we can help reduce pain. It certainly doesn't fix the problem or fix the underlying issue, but it can help reduce pain and improve people's quality of life. In the knee, I'll just give you a brief example. We know the nerves that give feeling to the knee. They're called the genicular nerves, and there's some on the inside and there's some on the outside. And we know where they are, and they're well defined where they are from research studies. And we can stick the needle tip down to the level of the knee, and we basically heat it up at 80 degrees Celsius for 2 minutes and burn the nerves. And this is an example of the technique I use to do that procedure. Just to summarize, basically, in my practice, I use diagnostic blocks to help confirm the diagnosis by using dental freezing. I use corticosteroid injections to help with acute osteoarthritis pain flares and help get people back to activity. I'll do repeat injections every 3 or 4 months in people who are responders or who are awaiting joint replacement, but we do expect diminishing returns, and it might not be effective long term. The hyaluronic acid, as I talked about, will be a shock absorber lubricant that I use as a next line of treatment for symptomatic mild to moderate osteoarthritis, mainly in the hip and knee, but sometimes other joints. And then finally, we have the platelet-rich plasma, which I typically do an add-on. I usually use it later, and I usually do a series of 3 injections separated by 1 week, because that's what most of the evidence in the research studies show is effective. And finally, for people that are non-responders to all these treatments, we have the radiofrequency ablation, where I can treat the knee or the hip pain by burning the nerve endings. This is usually reserved for the non-responders or people awaiting surgery because it's a kind of a more invasive procedure. So thank you very much for having me. That went by quickly. So I'll try to join the session later and answer any questions that there are for myself. Thank you very much.